Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Welcome back to the Deep Dive, presented this week by the Surgical Edge podcast.
Great to be here.
Now, if you're a registrar, maybe a consultant, or really any doctor involved in the general surgical acute take, well, you know exactly what we're diving into today.
Acute cholecystitis management. It's a staple.
It is, and on paper, it seems pretty straightforward, doesn't it? Diagnose, maybe some antibiotics, schedule the cholecystectomy. Simple.
But it's rarely that simple in practice, is it? The reality is often messier.
Yeah, exactly. That pathway from turning up acutely unwell to actually getting that gallbladder out, it's often just fraught with logistical challenges, clinical bumps, systemic hurdles. You know the drill. It
really is the procedure that can highlight all the cracks in the system, I find. And that's what we're doing today, isn't it? A proper deep dive.
That's the plan. We're dissecting the NICE clinical guideline 188 CG188, looking at its sort of gold standard ideals.
And contrasting that with the daily grind of trying to make it work in the NHS nearly 10 years after it came out.
Our mission really is to unpack those key evidence-based recommendations, put them side by side with let's be honest, the intense capacity constraints you face every single shift.
And explore what that gap actually means for patient care, for your workflow, for everything.
Absolutely. But before we get into what the evidence actually says, the crucial reminder we always give.
Yes. This content is strictly for reference, for discussion. In your clinical practice, you absolutely must follow your local hospital and trust guidelines.
Always.
Yeah.
Okay, let's get into it then. CG188. It sets the bar, doesn't it? The ideal evidence-based care. What's the thinking behind it? What's the foundation?
Well, the foundation is really built on two things: efficiency and preventing recurrence. CG188 isn't just someone's opinion. It comes from quite extensive meta-analyses, cost-effectiveness modeling.
Right.
The main goal is to cut down variation in care and, crucially, to stop that patient merry-go-round. Prevent the painful, costly system-draining complications that happen when surgery gets delayed.
And that core idea of stopping the delay brings us straight to recommendation 1, offering emergency surgery. Is that mostly about safety, or is it the system efficiency driving it?
It's interesting because the rationale works on both levels. The guideline is very clear. Offer emergency surgery to people with acute cholecystitis, ideally within 1 week of diagnosis.
Ideally within 1 week. That's the key phrase.
It is, and the clinical data supports doing it during that first admission, what we call index admission cholecystectomy. It shows that if you have an experienced surgical team, the risks, things like bile duct injury, conversion to open surgery, they're pretty comparable to waiting and doing it later.
So it's safe.
Yeah.
Which then allows the system argument to come forward.
Precisely. From a purely system point of view, it's just much, much better. You're getting everything done in one hospital stay.
Yeah.
The diagnosis, stabilizing the patient, the definitive fix.
One admission.
One admission. You avoid all those costs, financial costs, patient suffering costs of sending someone home, only for them to bounce back in 3 weeks with more pain, or worse, gallstone pancreatitis, just because they were waiting for an elective date.
Yeah, that makes complete sense. Patient-centric, too, getting it sorted quickly.
Definitely. Now, moving on from timing, CG188 is also, surprisingly firm on the initial management, isn't it? That's key recommendation, too. Diagnosis and antibiotics.
It feels quite restrictive.
It is, intentionally so. NICE says you should not offer antibiotics unless the diagnosis of acute cholecystitis is confirmed. They want precision. They point towards the Tokyo Guidelines criteria.
So you need the clinical picture.
Yeah, the signs, the symptoms, plus the lab confirmation your raised white cell count, or CRP, and the imaging findings consistent with it. You need the whole package.
And the reason for being so strict?
It's all about antibiotic stewardship. It's a very deliberate stance against antimicrobial resistance, trying to stop us just automatically giving antibiotics to patients who might, in fact, just have severe biliary colic without actual infection or something else entirely.
Right. Forces you to pause and really confirm that septic element.
Exactly.
Okay. And then the third key bit, percutaneous cholecystostomy, PC. The guideline seems very specific about when this fits in.
Extremely specific. Key recommendation 3 basically reserves PC for a very particular group. We're talking the frail, the elderly, Maybe ASA grade IV or V patients or critically ill patients, often in ITU perhaps, with a calculus cholecystitis.
So people where a general anesthetic right now is just too big a risk.
Precisely. It is absolutely not meant to be a routine get-out-of-jail-free card or a temporary fix just because you can't get a stable, otherwise reasonably fit patient to theater quickly.
Okay, so that's the ideal world according to NICE. But here's where, as you said, it gets messy. Frustrating even.
Yeah.
Because the logic in CG188, you can't fault it. But the reality check of, NHS pressures, staffing, budgets, it hits hard. You're working in this resource-limited world that often just cannot deliver that gold standard universally.
And that's the fundamental conflict for clinicians on the ground, isn't it? Let's break down those friction points. Starting with friction point A, trying to actually do that within 1 week surgery, the guideline offers the patient surgery.
But it doesn't magically create the theater time needed.
Exactly. The elephant in the room is the emergency theater capacity crisis. Most trusts, you're lucky if you have 1, maybe 2 emergency theaters running 24/7, and they have to cover everything.
Yeah, the perforated bowel that needs to go now, the major trauma rolling in, the ruptured aneurysm.
Precisely. And compared to those, the acute gallbladder, even though NICE says operate soon, it often gets mentally triaged by the system, by the theater coordinator, as subacute. It's not immediately life-threatening in the same way.
So it gets bumped.
It gets bumped. Repeatedly sometimes. If you get your diagnosis confirmed on a Monday, but the week fills up with more urgent cases, hitting that 7-day target for everyone just becomes, well, impossible.
And that's before we even factor in the dreaded weekend barrier.
Oh, the bane of the acute surgical unit. Patient comes in Friday afternoon, maybe early evening. They've missed any chance of sneaking onto a Saturday morning elective list, if one even runs.
Right.
Then you hit Saturday, Sunday, where theater capacity is usually skeleton staff reserved only for the absolute most critical life or limb cases.
So your gallbladder patient just waits.
They wait, they're stuck until Monday morning at the earliest, maybe Tuesday. And boom, you've sailed past the 7-day target just because of the calendar.
And underpinning all this is the need for the right staff.
Yeah.
The senior surgeon conundrum. NICE talks about an expert team.
Which means experienced surgeons, consultants, senior registrars. And they're a finite resource, aren't they? They're pulled between the emergency take, their own elective lists, clinics, MDTs. Finding the right person with the right slot at the right time adds another layer of difficulty.
So you've got this patient. They're stable enough not to be crashing, but they're waiting. And waiting in hospital isn't benign, is it? That leads to the fitness roller coaster.
Oh, absolutely. They're in a hospital bed, maybe not eating or drinking perfectly. They're less mobile. They decondition. They might pick up a hospital-acquired infection, a chest infection, a UTI, maybe develop a bit of an AKI.
And just when a theater slot finally appears,
they're suddenly deemed temporarily unfit for the anesthetic or the surgery because of this new problem, so it gets delayed again. It's incredibly frustrating for everyone.
So all this friction, this inability to meet the ideal, it forces the real-world workaround, the hot list.
The hot list is basically pragmatic resource rationing, isn't it? It's the necessary evil, the deviation from the guideline, where the surgical team has to look at everyone waiting and decide, okay, who is clinically deteriorating the most? Who has been waiting the longest? Who is actually fit enough today?
Yeah.
It becomes this complex balancing act, prioritizing based on immediate need and system pressure rather than the universal 1-week rule. It's an ethical compromise driven entirely by lack of capacity.
Okay, let's shift gears to friction point B, antibiotic stewardship versus, well, clinical instinct or fear. The guideline's quite clear. Hold off antibiotics until you're sure. But in a busy ED at 3 a.m.
That's a really tough ask, isn't it? It's that classic diagnostic gray zone problem. Picture the scene. Patient comes in, looks unwell, severe right upper quadrant pain, maybe a bit of a temperature.
Yeah.
But the initial bloods are only borderline white count 11, CRP 30. And the quick bedside ultrasound scan is maybe equivocal, shows some stones, but no definite wall thickening yet. Is it early cholecystitis or just really bad biliary colic?
And the nagging fear is always missing that patient who's just about to tip over into full-blown sepsis.
Exactly. That fear of rapid deterioration combined with the sheer pressure in A&E to do something, to initiate a management plan, often means clinicians default to starting broad-spectrum antibiotics empirically.
Feels safer in the moment.
It often feels like the safest path, even if it technically goes against the strict letter of CG188. You're managing perceived risk based on deep-seated clinical instinct.
So the workaround here often becomes a sort of Start them but review quickly, like a diagnostic trial of antibiotics.
That's generally the pragmatic approach, yes. Start the antibiotics if your clinical suspicion is high, but, and this is crucial, have a very clear plan documented to review within 24, maybe 48 hours. Look at the trend in inflammatory markers, get the formal imaging report. If the diagnosis isn't confirmed, you stop or de-escalate the antibiotics promptly.
Right, trying to balance immediate safety with longer-term stewardship goals.
It's a constant tightrope walk.
Okay, friction point C. The misapplication of percutaneous cholecystostomy. You said it's for a very specific frail group, but we sometimes see it used more widely.
Yes, and this is where it can become what some people call the bridge to nowhere. It gets used as a temporizing measure, almost a holding strategy, for patients who are relatively stable, maybe a bit complex, but fundamentally aren't getting to theater quickly enough.
So instead of surgery, they get a drain put in.
Exactly. The justification given might be to cool down the inflammation, make subsequent surgery easier, but really it's often because an emergency theater slot just isn't available in a timely fashion.
And the consequences of using it outside that very frail group, does it actually solve the problem?
Well, it substitutes one problem, the need for urgent surgery, with several others. These patients often end up with prolonged hospital stays managing the drain. There are risks of drain-related complications, infection, blockage, displacement.
The drain falling out.
The drain falling out, yes. Then they get discharged with this drain still in place, stuck on a potentially long elective waiting list, still vulnerable to gallbladder issues, sometimes lost to follow-up. It can end up consuming far more resources in the long run than just getting the surgery done up front.
And this ties into that idea of justifying system failures, doesn't it?
It really can. Sometimes the decision for PC might be documented in a way that sounds purely clinical, patient-optimized via percutaneous drainage due to high anesthetic risk, when, if we're brutally honest, the primary driver was the lack of theater access that day or that week. PC became the only definitive action the team felt they could take. It can inadvertently mask the underlying resource deficit.
So stepping back, this constant conflict between knowing the standard, the CG188 ideal, and what you can actually do on the ground. What does it all mean? What are the real tangible consequences when we consistently fall short?
Well, the most immediate and obvious one is a postcode lottery of care. It's stark. Your chance of getting that index admission cholecystectomy within a week, as per the guideline, varies hugely depending on where you live and which hospital you go to.
So a big, well-resourced teaching hospital versus a smaller DGH.
Exactly. A tertiary center with, say, a dedicated acute surgical unit and ring-fenced emergency theater time might hit that target pretty often. But a district general hospital constantly struggling with staffing, bed pressures, theater access, they simply can't. So your geography dictates your care pathway, which isn't right.
And for you, the clinician, that failure to meet the national standard, it creates that medico-legal trap, doesn't it?
It's a massive vulnerability, both for individual surgeons and for the trust. If a patient develops a serious complication while waiting, maybe gets severe gallstone pancreatitis, needs ITU, has a prolonged recovery, they or their lawyers can quite rightly point to CG188 and say, this is the standard of care you were meant to provide, and you didn't. Defending that becomes very difficult when the reason for not meeting the standard was systemic lack of resources rather than a specific clinical decision error.
And what about the impact on the surgeons themselves, the morale aspect?
Oh, it's huge. It creates enormous cognitive dissonance. You're trained to follow the evidence, you know what best practice looks like, you want to deliver it, but the system actively prevents you from doing so day in, day out.
Moral injury.
That's exactly the term people use, moral injury. Being forced to practice in a way that feels suboptimal, rationing care due to constraints. That constant ethical strain, that feeling of letting patients down even when it's not your fault, it's a major driver of burnout and people leaving the specialty.
And ironically, trying to manage these patients conservatively or delaying surgery, it ends up being less efficient overall, doesn't it?
Completely. All those strategies keeping people in for longer observation, readmitting them when they get more colic, bringing them back months later for an interval cholecystectomy, they consume far more bed days, more nursing time, more diagnostics, and ultimately still require theater time, often more complex surgery later on.
Plus, clogging up the waiting lists even more.
Exactly. It feeds the backlog. The single, efficient admission pathway prescribed by NICE is actually, in the long run, likely the most resource-effective approach, even if it requires upfront investment in capacity.
So the gap is clear, the consequences are serious. How do we start to bridge it? What can clinicians and departments actually do now on the front line while we wait for those bigger, maybe elusive structural changes?
Well, the big structural change, the ideal solution, is definitely moving towards that acute surgical unit model, the ASU, with properly dedicated ring-fenced emergency theater time. Time that cannot be pinched for elective cases or other pressures.
But that takes major buy-in, doesn't it? Clinical and managerial clout.
It does. It requires a huge institutional commitment. So in the meantime, what's the compromise? What's working pragmatically?
Yeah, what can you do on Monday morning?
I think the most crucial practical step many places are adopting is creating a dedicated hot gallbladder list. This isn't the main emergency list, but rather carving out protected slots, maybe 1 or 2 cases on the elective theater list, perhaps once or twice a week.
Okay.
These slots are specifically reserved for those acute cholecystitis patients who couldn't get done within that first week. It ensures they get their definitive surgery maybe within 2, perhaps 3 weeks of their initial admission, drastically cutting the risk of them bouncing back critically unwell.
That makes sense. A structured safety net. And talking of safety nets, what about the patients we simply have to discharge home to wait for that hot list or an elective slot?
Safety netting for them is absolutely critical. You cannot just send them out into the void. It means really clear, unambiguous patient information, ideally written down explaining the red flag symptoms, things like developing jaundice, a high fever, uncontrollable pain, persistent vomiting.
And crucially, how to get back into the system quickly if those happen.
Yes, a guaranteed pathway for rapid reaccess to assessment, bypassing the usual ED queues if possible, a direct line to the surgical assessment unit, perhaps.
And alongside that, managing expectations through just honest conversations.
Absolutely. Transparency is key to maintaining trust, especially when the system is under pressure. We need to be upfront with patients, acknowledge the guideline, explain the local capacity limits, and clearly articulate the plan.
So saying something like,
look, the national guidance suggests surgery ideally within a week. Unfortunately, due to current pressures, we can't guarantee that right now. However, here is our concrete plan. We've placed you on this priority list. We expect to operate within X weeks, and here's exactly what to do if you get worse in the meantime.
Builds trust, manages expectations.
It does. And finally, the most powerful tool for change internally. It has to be data.
Data-driven advocacy, using the numbers.
It's the only language that often cuts through in management meetings. Surgical departments need to rigorously audit their performance against CG188. Track your index cholecystectomy rates, track your readmission rates for complications, track the length of stay for delayed cases.
And present that clearly.
Present the hard facts. Our compliance with the national standard is only 25%. This resulted in X readmissions last year, costing the trust an estimated £1 million in extra bed days and interventions. That kind of data is your strongest argument for demanding those ring-fenced resources that protected theater time.
It's a compelling case. This has been, well, a really insightful deep dive. It feels like NICE CG188 gives us the perfect blueprint, the what good looks like. But the reality of this system forces you, every day on call, to practice the art of the possible, which is often something quite different.
I think that's right. And connecting it back to the bigger picture, the job for us as frontline clinicians isn't to just shrug and dismiss the guideline because it's hard to achieve. It's surely about constantly striving to implement its core principles, that early, definitive care wherever we can.
While also fighting for the resources.
Exactly. While simultaneously, relentlessly advocating for the system changes, for the capacity needed to actually deliver that standard consistently.
And perhaps that's the final thought to leave with you, the listener, the clinician, grappling with this daily. This whole discussion really highlights a central tension in modern healthcare, doesn't it? That perhaps the greatest challenge to the contemporary surgeon isn't always the technical difficulty of the operation itself, but navigating the profound ethical weight, the moral injury that comes from working within a system that too often prevents you from delivering the care you know your patients deserve, the standard set by the evidence.
A tough reality.
It is. Thank you for joining us for this analysis. This has been a deep dive presented by the Surgical Edge podcast.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.